Welcome to Season 3 of the Ortho Insider Podcast, the podcast that goes behind the scenes of orthopedics in Canada and worldwide. Again, this year we are very lucky to have all the presidential carousel with us. So today we have Dr. Len Marais, who is an orthopedic surgeon who previously served as the head of department of the orthopedic surgery and subsequently as a dean and head of school at the Nelson Mandela School of Clinical Medicine at the University of KwaZulu-Natal. He served as the president of the South African Orthopaedic Association from 2023 to 2024 and is currently on the presidential carousel. And Dr. Marais specializes in complex limb reconstruction, orthopedic infections, and oncology, and is involved in global collaborative programs advancing musculoskeletal care and research in low-resource settings. We also have Dr. Mark Bowditch. He is the consultant orthopedic surgeon with a subspecialty focus in knee surgery. He is the current president 2024 to 2025 of the British Orthopaedic Association and serves as the divisional clinical director for musculoskeletal and surgical specialties of the East Suffolk and North Essex NHS Foundation Trust. Dr. Bowditch also holds academic and educational leadership roles, including being the head of the School of Surgery for the Health Education East of England, Cambridge, and consultant for the 40th Clinic in London. Gentlemen, welcome and thank you for being here.
And generally a good guy.
And I'm sure both generally wonderful people.
Yeah, it's a real pleasure. Thank you very much.
So, our first question for all of our guests is, how did you get into orthopedics in the first place? Maybe Dr. Bowditch?
Yeah, so at school, I was very sporty. I think many people in orthopedics often come from a sporty background. They have injuries and you end up being rather frustrated in terms of your treatment. So that would be where I probably started. I was a pretty good soccer player and I should say football, because that's what we say at home.
Call you on that one.
Yeah, absolutely. And an athlete. So I ran 800 meters quite often and at sort of national level. And I was injured and seeking access to orthopedic surgery wasn't easy. And so at school, I thought I was going to be an engineer. And then I really had no one in medicine in the family. And then someone asked me, do you like engines or do you like people? And I thought, quite like people. And, communication was important. Of course, I'm very naive at that stage. I felt, well, let's give medicine a go. And I can always drop out if I don't like it. And I stuck in it, I guess. And after that, I gradually ended up in... I like to do things, and the physicianly rounds for 4 or 5 hours started to get a bit tedious. So
I completely empathize with that.
And so the practicality, my first clinical attachment was actually orthopedics, and I loved it. And from there on, I sort of ended up having some really interesting mentors who ended up, like I guess we all have, if you have a really good attachment, you could do that, and you feel as if you want to follow in those lines. And I can tell you about all the mentors, but that's how I got into medicine. That's how I ended up going down a surgical line, and then it sort of went down the line of, well, actually, I quite like orthopedics. It's a transactional, do something and really get a outcome benefit straight out after it, and people are very thankful. Relief of pain, restoration of function, and seeing people get back onto the sports field or even just walk around their home. It's really, really rewarding, and I guess every area of medicine has its rewards and benefits in a different manner. But that's what gets me up every day and go from there.
Oh, amazing! Yeah, Dr. Marais.
So I just want to reflect on this because my dad worked as a chemical engineer. So when I was, I don't know, the age you do have that discussion, he sat me down and he said, so what do you want to be one day? There's mechanical engineering, electrical engineering, chemical engineering. So in those days, he says, which one? I said mechanical. And then, anyway, so then I burned when I was at school. And there was a plastic surgeon look after me, and I thought that was cool. I want to be a doctor. So I changed all my subjects from all the stuff you do for engineering. And then at medical school, I did quite well in general surgery. And there was a registrar in general surgery that, that attachment just appealed to me. And I thought general surgery is cool. And I did quite well in it. And before I left medical school, I actually spoke to the head of department, and I said, I want to come specialize. He says, cool. And it was all sorted. When I went to Ishawi, which is a little town in Zululand, northern KwaZulu-Natal, big hospital, 500-bed hospital. There's only 6 interns and maybe 6 other doctors. So you do a lot. I started doing a lot of surgery because I was the only one there interested in it. There was one ex-Russian or Polish surgeon as well. That's another story. But and then there was an orthopod who came once a week to do some orthopedics. And as I was in surgery, I started to help him. And I thought, geez, this is much better surgery than general surgery, where you do stuff and just check the abdomen the next day. You don't know what's going on. You can't see. I mean, and so I actually had to write, or I phoned him. I can't remember. The previous head of the department said, I'm sorry, I'm not coming anymore for my registrar post when I do orthopedics. It was a very short call. But then he wasn't very happy. But then I went on to orthopedics, and I like the similar things, which I think appeals to all of us: the practical nature and the fact that you can see genuine outcome.
So I remember going to interview at medical school. I can't remember which one it was now, and they said, "What do you want to do?" And I said, "Oh, I think I'd like to go down sports medicine." And at that stage, sports med wasn't a career at all. No, it was a long time ago, Adrian. What is the benefit in that? And so I thought, there's a real good chance that this is a developing field and I might be at the front of it. It was a developing profession, or subspecialty, I guess. But I really felt that, I wanted to be able to operate, and being exposed to that in medical school and early years afterwards, I really got drawn to surgery. And then in our training system, you don't choose your subspecialty straight away. You tend to experience a variety, a sort of rotation. You do general surgery, you do urology, you do plastics. And each one of those was really quite engaging for 6 months or so. You could see yourself doing it, but then you have to think, could I do this for 25 years or more? And so I kept drawing back into the orthopedic link. And I've gone down the line of knee surgery, partly because there was quite a big element of that in sports and ligament reconstruction, which still is a considerable part of my practice.
If you weren't an orthopedic surgeon, what other surgeon would you have been?
Well, I actually really enjoyed general surgery and the technical skill of colorectal surgery at the time, which is
that's a bit from arthroplasty to
absolutely. But it at the time, that was also often held up as a pinnacle of achievement within surgery, and the old school general surgical picture, that was where the best, and I'm quite competitive, and so I thought about that. But at the end of the day, it's sad to say that some of the specials deal with dirty areas, or orthopedics is quite clean,
very clean, very civilized surgery.
And so, from that respect, as a junior, you spent a long time doing sigmoidoscopies, and I got put off in the end of that as a career of life. I hate to bring the level of this discussion down a bit, but
so it's funny you should say that, because my experience with general surgery also. I also thought I wanted to be a general surgeon first, and then a plastic surgeon, actually, before ortho. Yeah. But I had the same experience with sigmoidoscopy, and I was like, maybe this isn't for me. Yeah. But Dr. Marais, tell us about your interest in plastics, because I was interested in that because I thought it was very creative. It was very elegant. The reconstruction was, really cool.
So the cosmetic work I get, but for me, and it comes in with my especially my infection and limb reconstruction work, especially where we are, where there's very few plastic surgeons, in the public sector. So I do some of the flaps still myself, like soleus and gastro flaps. And I really like that. I wish I can do free flaps. I've been thinking about going to learn how to do it. But, there's just, I know, in France they do it.
Yeah.
I went to visit that, when Musculate came out, I went to go there, and those French guys do their own free flaps. But anyway, so I like that limb reconstruction side of it. And it's like it's also, you see what you do. You do a beautiful flap, and you don't get that with the other surgical disciplines so much. So anyway,
So I think in the UK, some people still do their own flaps as part of a revision arthroplasty around the knee, but I think that's dying out, and I think we push a close working relationship with respect to orthoplastics, so you can bring the best of your own skill set to it and work closely. And we're increasingly seeing dual operating in many of these more complex type interventions. We do have a plastics and hand overlap, plastics and orthopedic hand overlap specifically. We have until I think recently, we still have at the moment an additional training segment we call a TIG training at the end of training, which allows you to go into the other specialties for a period of time, which is paid for. As far as I know, that might be removed due to various governmental changes, but
still existing now. So, but the principle of having that dual kind of subspecialty expertise in one case, I think, is really, really important. It's actually a really good segue because you both have mentioned, flaps and infections and things. And, Dr. Marais, obviously that is your area of expertise. You have a doctorate in it, and Dr. Bowditch, I mean, in your inaugural speech, you mentioned the importance of preventing infection. Can you both talk to a little bit about the importance of that in kind of your respective areas? Dr. Marais.
Yeah, so I think that we spoke a little bit before the podcast about the shortage of orthopedic surgeons in South Africa, especially in the public sector. Let's say our province is 12.4 million people. What we've got, and there's, I think, 40 odd full-time orthopedic surgeons in the province. So what you've got is medical officers in the more rural hospitals doing primary care of open fractures. And often they will be 1 or 2 years out of internship. I don't know what internship in Canada, but so they have very little experience with very little oversight. There's no consultant there.
And they're just out there doing it by themselves?
They're just out there doing it.
Wow.
So, and there's, even in the bigger centers, there's about 11 hospitals that does orthopedics. The guys who's there, there's overworked, there's so many patients, and so patients wait long, there's systemic issues. And so bottom line is we get a lot of infections after fractures. And that's kind of, and interesting, it was always my interest when I specialized in orthopedics, I was interested in infection. And then when I started working in Pietermaritzburg, there were so many infections that, I just, that's always been my kind of interest. The problem is the resources. If you go to Europe, we were talking about plastics now, Oxford, Basel, so many places with big infection units have their own plastic surgeon who only does infection work with it. So to explain that. So, and we barely have one plastic surgeon in a town of 1 million plus people. So, but it's always also good to have diversity in your team. So I don't know if it would have been good if I did all the flaps. It's good to have another person in that team. So,
absolutely.
I think infection is the enemy of any of orthopedic specialties, really is. And if we forget that, then we're doing great disservice and it will catch us out. And in terms of my theme or our association's theme for this year, it's prevention. And prevention in a very broad sense, preventing disease or illness or injury occurring in the first place. But we like intervening, we like operating. Well, let's try and reduce the number of complications, or let's reduce infection, which, all of us wake up at night anxious about a potential infection that might be occurring. And if you can prevent it in the first place by good behaviors, good surgical techniques, good structures and following processes with antibiotics, protocols, etc., and then it's far easier to prevent rather than treat. In terms so I think that's my aim is to propagate that first, and then when you have an infection, treat it quickly and treat it appropriately with the best evidence-based treatments. And these things are expensive. You know, some people say that it's at least 10 times, if not 20 times more to treat a patient with infection of a joint replacement than it was to try and prevent it in the first place.
Absolutely.
And so in the UK, we recognise that as a difficult area. It's important to be multidisciplinary, and it's important to involve all aspects of that multidisciplinary team to get that treatment right in the first place. So we're perhaps cohorting that expertise. So not every hospital will offer that service. So we have a plastics service that might have 6 or 7 people that can, and they'll do outlying hub and spoke sort of clinics, and we'll refer from smaller hospitals to bigger hospitals, so they can provide the expertise, and particularly with the microbiology expertise, radiology, all aspects of the MDT team and then the nursing teams and support, which are absolutely vital to pin sites or whatever, things like that.
So it's very interesting because you seem to, the two of you seem to come from very polar opposite practice types. Dr. Marais, you have one plastic surgeon for a population of 12 million, whereas, Dr. Bowditch, you have centers of excellence. Being on the carousel together for the last little while, like, what have you learned from each other, and what do you think you can bring to each other's home countries to kind of improve on this topic of infection?
So we've actually been, our associations has been collaborating for a while. So we've, on education, we subscribe to their journal. This has come for a while, that there's been we're sending a lot of people for fellowships in the UK. So I think there is a strong collaboration, and it starts to speak to your global health issue that we spoke about earlier, is that I think the rest of the world is recognizing the problems that there is in the lower middle income countries, and there is stronger collaborations. For example, there's a lot of research going on in open fractures now. That's sponsored by UK, and there's strong collaborations with Matt Costa's group and through our university. So I think research is one place where we've been collaborating a lot with the UK.
I think the collaborations that you've got, the actual the clinical cases that we in greater numbers than we might not have, and it's about understanding that, or getting that bigger cohort in order to answer that research question. And we might have a lot of academic support to ask the right question and provide the right analysis of it. So we can link up and decide which questions need to be answered. So and that's one of the things that the BOA and the British Orthopaedic Associations, or the British Orthopaedics as a whole, has been focused on. Its sort of pragmatic clinical trials in terms of innovation, actually answering the question rather than just applying the treatment and hoping that it's going to be correct. And we've really worked pretty hard as a country to develop that, and I'd say we've got some absolutely fantastic researchers across some of our institutions that are answering global questions, even relatively simple ones. It may not just be around infection. It will be cement or no cement. It'll be cast or no cast. I don't know if you've seen some of Dan Perry's work, the pediatric consultant. Some of those really quite basic questions, asking those things that we've done forever, and unraveling those.
Just challenging the status quo, challenging those dogmas.
Yeah, and I think that's, we're doing the same within my specialty, within knee surgery, and there's this world developing or galloping towards robotics, and so we've got a study called Radar, which is looking at that and trying to answer that question as to, is there value in this, is there benefit? And one of the criticisms with orthopedics in the past is that we grab hold of an innovation and run with it for a number of years, and then perhaps we shouldn't have done. And so I think we're trying to debunk that theory that orthopods aren't researchers, and I think we really are. And I'm been so impressed with some of the colleagues who are leading that work, and you see a lot of this on the BJJ, and
Faris Sadat was here last year chatting about that. He was wonderful, right? Brilliant guy, right? So,
and the team that we have together in the orthopedic world, I'm really proud of. And talking about those developments, it's critical that we see innovation brought forward, but actually brought forward with the questions answered to some extent, rather than just trying it on populations and finding out in a crude manner later.
So I love that you said that. So last year we had our COAG, Canadian Orthopaedic Association Global Surgery series, and a big part of that was innovation in orthopedics and how can we use that and harness that to apply to local, kind of urban populations, but also to the underserved populations. What are your opinions on that, both in the urban and maybe underserved population? Because, with the advent of things that we talked about last year, such as mixed reality, mixed or augmented reality, virtual reality, it could have impacts on training, human resources, because we may not need as many people anymore, things of that nature.
I think one of the things that we're probably seeing in our country is lack of access to clinical activity in training and education. So the numbers of activities, because of the way that patients often want the most senior person to do the operation, so people are less experienced. So you mentioned augmented reality and ways around that is if you can upskill people, so that some of that basic elements of knowledge is already on board before you have your clinical contact. You can make more value, more opportunity out of your clinical surgical intervention, because you've already come over a number of steps. I think that is a use. And also things like cadaver usage in terms of education, they're really quite high fidelity, they're quite expensive to arrange, and whilst they're very, very valuable, we may have less access to that. So if that again can upskill you to you really focus on the bit that you're going to get the most benefit out, and then transfer that to the clinical case, we might need fewer clinical surgeries or interventions to achieve a competency level. But, surgery is a lifelong learning in many respects, and the things I'm doing now, was I competent when I finished my training? No, absolutely not. You have to change. You develop competencies, you work out what works in your respect and in your own hands, and also you take on new interventions. And so I think all of these multiple ways of learning can be really helpful in that sense.
Yeah.
So, this is going to be a long answer. Firstly, okay, I'll get to the MIT thing. So, in South Africa and in the developing world, where there's a need for these kind of global interventions, there's no money for innovation. That is the last thing. We can't even, I don't know, I don't want to, we haven't had 2.0 for months, but that's an example. So if there isn't money for these kind of, what I think global health should look like is personal contact. If you, and you say your guys don't have enough clinical exposure, if they come to South Africa, they'll get as much clinical exposure as they can handle, but that builds the collaboration. And this has happened. We've seen this. People who've worked in Africa, in Malawi or South Africa, wherever, that they will always have that relationship, and have that global picture of orthopedics. So, if you're going to spend money on global health, we must spend it on individual contacts. You must come work in South Africa. Yes. You will have that connection forever. And then, what I think, getting back to your question, how can innovation then help? What I would like to see is you go back to wherever, Vancouver, and then you run an online shoulder clinic or an educational event with your people that you know in South Africa once a month, and eventually that collaboration will mean exchange, fellowships. So I think if we're going to spend money, we need to build that. People should have a connection somewhere else in the world, and that will lead to us really being a global orthopedic, where you don't have just British Columbia, but you've got a little bit of South Africa in your orthopedic practice. But it's going to cost us a lot of money. I don't know who's going to pay for all of this.
Yeah, it's so wonderful you said that. I love innovation. I love technology, but I always believe that there is going to be a personal touch on top of it.
Yeah.
And so I think that's what you're getting at. And we're very lucky. Where I did one of my fellowships in San Francisco, University of California, San Francisco, they have the IGOT team, who they do exactly that. They're plastic surgeons and orthopedic surgeons, where they actually will go to the area, but also bring those surgeons back to San Francisco and teach them how to do flaps, for example, right? And similarly, you stop here at UBC, just a very, very similar thing. And they've published highly on that these longitudinal relationships can actually highly alter like the course of basically local orthopedics. And I think, they built residency programs. It's been wild. So your point, I think, is very excellent in terms of having that personal touch on top of the innovation. Yeah.
No, sure. And I think that we talk about educational fellowship exchanges. I think they're useful. One of the difficulties that we've seen is that we have a relationship with a number of different countries, bringing people to the UK, actually sending residents or trainees out to those countries. There's a difficulty. Who's going to pay the mortgage for the house at home?
Totally. Yes. Because we both come from very high cost of living areas, right? Vancouver and London, England, right?
And so we've been trying to persuade our providers, essentially money from the government, and they say, well, why should we pay for that person to go to Sri Lanka? How is that going to be particularly benefit? We're giving the money to the hospital. Who's going to pay for that individual in that hospital to backfill? So there becomes a bit of a difficulty, and it's only certain individuals are able to take that opportunity. And when we have done that, we have tried to support it, but it's based on an individual, and those are local arrangements. And I think the wider benefit to the home orthopedic setup is definitely there. Because whenever you go and say, I'll come and work with you, I'm sure I'll pick up something about the setup, the positioning, or something we haven't thought about. So I think that's one of our areas of trying to promote. Research is another, but also developing, I think you described it as longitudinal connections. Some of our affiliated societies, particularly the Hand Society, have been connecting low and middle income sort of senior trainees or residents with those in high income countries to allow them to create a WhatsApp group or whatever it might be, and to share cases, and those then last for 20 or 30 years. And I think same with the ABC Fellows type setup. It's a lesser version perhaps of that, but it allows that connection, the sharing of cases, the sharing of research or ideas that helps support countries that might otherwise be less endowed with opportunities to change or develop and bring forward. So I think that's a really useful international collaboration project.
So that goes back to curriculum development, right? You're both head of schools for your respective universities and areas. And Dr. Bowditch, you worked on the curriculum, I think, 2017 to 2020. In Canada, we're actually actively trying to alter our curriculum to be more competency-based. How do you change that curriculum to entice people to do more of, well, number one, be in orthopedics, and number two, maybe do some of these things that are more important worldwide, and in Dr. Marais, in your area, to actually hold on to people who will be there locally to serve?
So, so we struggle. The main problem actually that we have in the last part, keeping people in that sector, is actually just funding from the government at the moment. In fact, I found that a lot of people want to stay if you create the right environment. But unfortunately, because there's limited posts, a lot of people have to leave. And so this is just my impression. I don't know. I don't have the stats. But my feeling is that in our setting, people feel a sense of accomplishment in working in that environment and want to stay. But then there's not enough posts for people to stay. So yeah, maybe that's another perspective. I don't know.
We have very different systems that provide our health in various countries. So sometimes it's difficult to transfer one system to another. And I think that one of the issues that we have in the UK is, at the moment, we feel as if the training from leaving medical school to becoming a consultant is a bit too long.
Yes, right.
And
tell us about that process.
yeah, so in the UK, you tend to go to medical school out of high school.
Right.
We don't do a degree first, which I think you might do here.
We do, yes.
So you can come out of medical school at the age of sort of 22 or 23, and you then go into a foundation year, which is effectively your internship, but that's 2 years, and those might not be in orthopaedics at all. They might be in some surgical specialties, they may not. It's a real broad spectrum, so you might do 6 specialties. Part of growing up, part of maturing and being the wider aspect of medicine, which was medical council felt was very important. We used to do 1 year, it's now 2. And then you do a sort of core surgical training, which is generally 2, can be 3 years. Again, they tend to be themed. Yeah. So if you want to be an orthopod, you out of that 2 years, 1 year might be orthopedics, the other bit might be plastics, general surgery. And you used to do a fair bit of going to theatre during that time. Unfortunately, with ward duties and on-call duties and time reduction, time limits of 56 hours a week of work, your access to clinic and access to theatre is relatively small.
Yes.
So then you get yourself onto, you would call it a residency program, we would call it a training program, which is 6 years. And so we've written the curriculum for that, which is not dissimilar to, I guess, your curriculum, which is competency-based. And when we revise the curriculum every 3 years, but there was a major change in 2020, which our medical council directed with certainly certain requirements like full breadth of orthopaedics, acute take, on-call sort of safety, and the broad principles of orthopaedics. So you do all the exposure to all the specialties. Yeah. And then in the last 2 years or 18 months, you can subspecialize. You effectively can do an internal program fellowship. The actual practicality sometimes of getting people through all of those subspecialties means that you might not be able to do it in 4 years. It might take 5 years. You've got to pass the exam, which is a similar exam, oral VAR. That might take a couple of goes, for example, and then you've run out of time. But you can have additional time added. Actually, you can be appointed as a consultant at that stage. You're competent. You don't have to go on a fellowship. But 99% of people do go on fellowships, partly because the jobs that are subsequently advertised are desirable fellowship and becomes a competitive market.
Absolutely, yes.
And with the reduction of clinical exposure to operating, often during the program because of the hours restriction or shift work even. So looking at the Canada system, the US system, where it seems to be shorter, I think you work many more hours during your sort of residency years, and I'm not sure that we can go back to that. That used to be the case. Yeah. So it's about trying to make more use of the hours during the week for training purposes and cutting out the work or the activities that are less useful. Yeah. We don't have a lot of assistants, and the ward duties take up a fair bit of time, or the on-call duties. So I think that's the balance. It's not they're not quite easily comparable. So saying it's easier in Canada because you're through in 6 years and out you go, then the systems aren't quite as comparable. But I think we've got to work on that.
So getting back to the original, so we actually quite similar. We got the 6 years medicine straight out of school. Then you got 2 years internship. Then we've got a community service here where they send you to somewhere in a rural setting where you got to work. Then 2 years typically MO, and then you go 5 years.
MO is medical officer.
No, but as a medical officer, but you can't generally get into orthopedic program if you didn't work as an MO in orthopedic department.
I see.
So it's kind of an entry requirement for most of the places. And then 5 years. So it's not a lot short.
And in South Africa, you go into your medical school also right after high school?
Yeah. There's no So it's difficult to get in there. And there's a lot of stories around that. But getting back to the curriculum, we also redoing ours.
Yeah, interesting.
For orthopedics, I mean. And I was involved with it. I don't like the competency-based thing. I think if you had to list all the competencies you have to have as an orthopedic surgeon, I think it's an endless list.
Yes.
And once you do that for all the people, it becomes just like some noise. Like practically everybody's giving 5 and 6s to everybody, and the end you got 4,967,000, and who's competent and who's not. I think it's difficult to find the signal. And if, as a trainer, I find that most often the problems, then people who really struggle, it's not a problem with competency as much as other issues. So, and this is where the entrustable professional activities come from. So if you ask me, name me the competencies an orthopedic surgeon should have, you should safely be able to do a ward round. You should safely be able to see a patient in the clinic. He should be safely be able to do theatre cases by himself. So, and you should be able to trust him to whatever. So we've got a list of 20. Yeah. And those can be assessed, work-based assessments, and which is similar. You've got a very nice one, your assessment, which I've actually, I like doing it. But a lot of it's like narrative feedback. Like at the end, you give a feedback of 6, of the last 6 months of this registrar, this is your narrative feedback on this. And that's often more valuable than assessing tick boxes. Okay, he could put in a K-wire from this side and this old patient, and then, so I think it doesn't, and that's that thing I showed in New Zealand, that, breaking down everything in these little groups, competency, this, doesn't give you the one thing.
We've also kind of refined ours in Canada as well, and we moved from this very technical, like checkbox, and now back to like a global narrative type feedback as well. Because I think what you're both saying is that trust and relationship, and again, if you're sending people out there to to do things on their own, you have to be able to trust they're going to do a good job, essentially, right?
I think the Canadian, I'm not. The Australian and the British one are fairly similar, and British and Irish, because we have the same program. Yes. I'm not so familiar with yours, but they are on those 5 activities of an orthopaedic surgeon. Actually, 5 activities of a surgeon are the same. And you've got the professional activities, the entrustable professional activities, or whatever each country calls that, as to needs supervision, needs a little bit less supervision, can do, is safe, is a master, and you sort of gain those. Yeah. And we've really tried to come away from the tick box to more of a group of people giving a feedback as to, I think this person is ready. Yeah. It's only taking you 3 or 4 cases to be ready. You've demonstrated you're competent, as against it might take me 20 cases. And it's an individual assessment. Yeah. And tried to say, well, you don't need 100 hip replacements if you can be good at 20, because there's some people who are.
Exactly, yes.
And otherwise, we've got someone wanting to do shoulder surgery who's still chasing 2 more hip replacements,
which I'll never do again in my entire life.
Ridiculous.
It's crazy. Yeah. What I've also picked up from this conversation, though, too, is that we talked before this about standardization in certain parts of orthopedics. We were talking more about billing codes and fee codes and whatnot. But there has always been kind of talk about maybe standardizing education and credentialing. But again, it just sounds like that the needs of your local environment are so vastly different that it actually, you almost have to customize. You almost cannot standardize. And even though it makes it right now harder, for example, for us to credential surgeons coming from other countries, it may just be what it is. And would you agree with that or disagree with that?
So in South Africa, actually, there's a greater need for a good general orthopedic surgeon.
Yes, exactly. Yeah.
Than subspecialists who can only do, elbow surgeons. But unfortunately, we're fighting science and human nature, and people want to do fellowships. So, so yes, but you're right. We've got a very strong trauma-orientated curriculum, because it's everybody does trauma. Even if you are in arthroplasty, you'll do hip trauma or whatever. There's just so much of it. So I think, yes, it influences the curriculum, but I know this is maybe a bit controversial, but I think, in South Africa, there's still a need for a good general orthopedic surgeon who can do a carpal tunnel, a knee replacement, and whatever,
Yeah, no, I think that's because our systems are different. And actually, if you go to the US, you think it's a highly specialized country in terms of that everybody's super specialist, but they're not. They still got quite a number of generalists.
Absolutely.
We don't really have generalists in the UK because our distances are so small, and our hospitals have a certain number of orthopedics, and they at least have 12 as a minimum these days. And so you can subspecialize within your hospital. So we all do trauma, and that's important because we're all part of the take team. Unless you become, after 20 odd years, you can come off,
Sure.
or whatever. That's how we've arranged it, and so that there's no need to be a specialist in the foot and ankle as well as the shoulder, or spine and hand. You would never wish to do all of those regions. And quite frankly, if I said to you as a patient, look, I'm a generalist, I do a bit of everything, they'd be run a mile from my door. I want someone that does hip replacements every day of the week doing my hip, and I even think that.
Gentlemen, thank you so much for such an in-depth conversation and sharing the differences between your respective organizations and countries. Dr. Bowditch, Dr. Marais, thank you so much for being here. We really appreciate great chatting with you guys.
Thank you. It was very interesting. We enjoyed it.
Thank you very much. It was great. You do a great job. Well done.
Oh, you appreciate that. Enjoy the carousel.
Thank you.